including aorta. And when inflamed, these vessel walls, they become weak and narrow and can cause thrombosis, aneurysm, and they can also rupture, causing hemorrhage. The clinical features of these vasculitis are varied, and it depends on the site and type of vessels affected. This is about general vasculitis in general. So this classification of vasculitis has been done uh, by two committees. First one was in 2007, and the Chapel Hill Consensus Conference 2007 classified, and later on it was revised in 2012. So this classification, according to 2007, was a simple one, and they classified vasculitis into three categories based on their caliber of the vessels and the etiological process, as large vessel vasculitis, medium vessel vasculitis, and small vessel vasculitis. But then they realized that there were many vasculitis or many diseases in which both medium and large, or large to medium, or small and medium vessels are also affected, and not all organs are affected. So they reclassified it in 2012 as the following: that large vessel, medium vessel, small vasculitis were there. But they also said there are other varieties are variable vessel vasculitis, when any one of them can be affected. Single organ vasculitis, vasculitis associated with systemic connective tissue, vasculitis associated with infections, and some other miscellaneous groups, including drugs and substance abuse. So we'll talk a little bit about each of them. This large vessel vasculitis, the prototype of the diseases is Takayasu arthritis and giant cell arthritis. The medium vessel vasculitis is characterized in diseases like polyarteritis nodosa and Kawasaki disease. Small vessel vasculitis can be further divided into anti-neutrophil side of ANC associated vasculitis, which is microscopic polyangiitis, granulomatosis with polyangiitis like Wegener's, eosinophilic granulomatosis with polyangiitis, Churg-Strauss vasculitis, and immune complex associated vasculitis like antiglobular basement membrane vasculitis, cryoglobulinic vasculitis, IgA vasculitis, and hypocomplementemic tricarial vasculitis. So these are the various vasculitis of small vessel vasculitis. All of them do not affect the brain, but many of them, they affect the brain also. This variable vessel vasculitis, which affects any type of vessels, medium, small, or large, and any type of vessel, that means including arteries and veins and capillaries also. They are seen in Behçet's disease and Cogan syndrome. Then we have a single organ vasculitis, because they found that certain vasculitis, they affect only one organ, and they have vascular inflammation of arteries or veins of any kind of any size, but restricted to a single organ. And this under this category, we have primary angiitis of CNS, PACNS, or primary CNS vasculitis. Non-systemic peripheral nervous system vasculitis also is there, and idiopathic aortitis, which affect the aorta. Then the other group was vasculitis associated with systemic connective tissues like rheumatoid arthritis or SLE. Then vasculitis associated with infections, many infections, bacterial, viral, mycobacterial, and even SARS-CoV-2 vasculitis was also associated with vasculitis. And the miscellaneous group, certain drugs can cause vasculitis also. We're talking about this is the general type of the classification of vasculitis. What are the various kinds of vasculitis as per the Rheumatological Association of America? So, but we come to the CNS vasculitis. Now, CNS vasculitis it refers to a spectrum of diseases that results in inflammation and destruction of blood vessels of brain, spinal cord, and meninges. This destruction of vessels all leads to decrease in the lumen size of the vessels, and it can cause ischemia, or it can which can lead to tissue damage. It can also lead to aneurysm formation due to weakness of the vessel wall, and these aneurysms can rupture, causing hemorrhage. The term angiitis is sometimes used to refer to blood vessels of both arterial and venous side of the circulation. So it is also sometimes called primary angiitis of CNS or primary CNS vasculitis. Both are synonymous, and I'll be using these two terms in the for this particular disease. So CNS vasculitis, I told you, can be primary or secondary. Primary CNS vasculitis involves confined to the central nervous system, and secondary involves the CNS also, but can involve other organs also, like inflammatory process, infection, other systems. So main emphasis will be on primary CNS vasculitis, IPCNSV, or primary angiitis of CNS, which I'll be covering in detail. And little bit I'll talk about secondary CNS vasculitis and some prototype secondary CNS vasculitis, which we see, which can involve the brain. So primary angiitis, CNS vasculitis or primary angiitis of CNS, I'll be talking in detail, which is the one which we rarely diagnose and often it is missed. Primary CNS vasculitis is a rare form of vasculitis that is limited to involvement of central nervous system, that is brain, spinal cord, and leptomeninges only. No other organ is involved in this form of vasculitis. The incidence is reported to be 2.4 per million population. It was first described by Herbitz in 1922, and this is a single organ vasculitis, as I told earlier, and it can
Hello, hello,
yes.
Andy.
So you are hearing the topic now.
Yes, sir.
It affects mainly the small and the medium arteries of the brain, spinal cord, and leptomeninges, and they produce various signs and symptoms. The clinical features are varied, and that is the most difficult part to understand. What is the etiology? The etiology is basically unknown, but certain infective agents like varicella zoster, West Nile virus, mycoplasma, HIV, and even SARS-CoV-2 has sometimes been implicated. There is some role of cerebral amyloid angiopathy in this, and they say that it can act as trigger if it is there. There are some genetic factors also, not very well defined. We'll talk a little bit about them. And the inflammatory process causes the vessels to become narrowed, occluded, thrombosed, causing tissue ischemia. And this affects mainly the cerebral cortex and leptomeninges, the blood vessels, but the subcortical regions are usually spared, but they can be involved. The pathogenesis is that because it is the integrity of the blood-brain barrier, which is important for the integrity of the brain, it is disrupted. And this is the most important factor in the pathogenesis. And why it is disrupted? Because there are both immune system and inflammatory responses which come into play. And they affect the blood vessels, and they affect the blood vessels by three mechanisms, either by immune complex mediated processes, by a complement, or by cytotoxic CD8 and T cell mediated, which releases interferon gamma and which activates the macrophages and destroys the vessels, or it can be the ANCA mediated inflammation and damage. There are the genetic factors which have been found to have some role. They are not well studied, but some HLA loci like HLA-B interacting with CD8 T cells and natural killer cells, they have been involved. SER-Serpina gene 1, including alpha-1 antitrypsin, is also involved. There is one gene called PRTN gene, which encodes PR3, and PR3 ANC vasculitis is involved in that also. So there is some association in sometimes it is found, but not always. So there is some role, they say there is genetic, but the genetic basis is not well defined. The inflammation of CNS vessels told you that leads to thrombosis and necrosis. The clinical features. Now, these clinical features are varied, and there is no pathognomic clinical feature. That is the most difficult part of this particular disease. There are varied signs and there are varied symptoms. The clinical course also varies. It can be acute, it can be subacute, it can be chronic progressive, or it can be even relapsing and remitting. And this can present as focal neurological deficit, non-focal features, encephalopathy, or cognitive changes alone. The various symptoms which have been uh, reported in literature, that headache is probably the most common, is found in 60% of cases, followed by stroke or TIA, which is in about 50% of cases. But other symptoms like seizures, encephalopathy, dementia, cranial neuropathy, aphasia, visual impairment, ataxia, coma can occur. Even myelopathy can occur if there is involvement of the blood vessels of the spinal cord. There was one study by the AIMS group, AIMS New Delhi, in which they studied which was published in 2022. It was a retrospective study of 85 cases of primary CNS vasculitis found there between January 2010 and 2019. 50 cases were biopsy proven and 32 cases were angio proven. Median age at presentation in this particular study was 34, ranging from 27 to 42. In this study, the seizure was the most common thing, which was 70%, followed by headache, which was 60%, hemiparesis, which was again around 50%, 55%. Cognitive impairment, visual impairment, and ataxia was also found. Paraparesis was also reported in around 34% of cases. And in this study, the fever was not found in any of these cases. The abnormal CSF was found in 87.5% of cases, and abnormal MRI brain was found in 85% of cases. Spinal cord was in 6.1% of cases, and both were present in 8.5% of cases. This was a study from our own country, which was a large study by the AIMS group. So how do we define or diagnose primary angiitis of CNS, or primary CNS vasculitis? The first, it was classified by the diagnostic criteria was given by Calabrese and Melick in 1988, but was modified in 2009. The Calabrese
नहीं मैं तो गोवर्धन मंदिर में हूँ
Calabrese and Melick criteria of primary angiitis CRS, which was in 88, it was simple. There is history of presence of acquired or unexplained neurological deficit without deficit despite aggressive evaluation with no other cause is found. So any unexplained neurological deficit in which cause is not found, plus there is evidence of vasculitis by histopathology or by classic angiographic features confined to CNS, which we will discuss, that is from some narrowing of the arteries. And there is no other evidence of systemic vasculitis or other disorder that can cause or mimic angiographic features. But this thing was a challenge because we cannot do histopathology or angiography in all cases. So this was a good thing which was decided with good criteria, but it was modified in 2009 by Birnbaum et al. And company. They said, okay, when we do not have a histopathology, then we should not call it primary angiitis. So they divided into definite primary angiitis of CNS and probable primary angiitis of CNS. So definite is when there is presence or history of acquired or unexplained. And unexplained is important because we do not find any cause for that neurological deficit, and we have a biopsy proven or confirmed presence of vasculitis. So for having a definite vasculitis, we can call only when there is biopsy proven evidence of vasculitis in brain, biopsy of brain. Probable PNS vasculitis or primary CNS vasculitis is when there is same thing, history or presence of acquired or unexplained neurological deficit, plus there is characteristic angiographic finding or abnormal MRI brain, plus there is also abnormal CSF consistent with primary angiitis of CNS. So if we are not able to do, which in many cases we are not able to do biopsy, which is a difficult and invasive procedure. So they said then we should not call it definite, we should call it probable, because the treatment is probably different. So the treatment requires for probable and definite should be different. That was the thing. And the bottom line on all these things is that is in absence of when we do not have histopathological confirmation, then we can use the angiographic criteria along with abnormal MRI and CSF criteria when we do not have, and when both of them are present, suggesting primary angiitis, then we can call it probable primary angiitis of CNS. So in neuroradiology, which is the most important thing, non-invasive investigation, we find some kind of multiple infarcts or any in any patient who presents with any neurological deficits, some non-specific infarcts or findings. But we find that there is focal narrowing, which I don't know whether you are able to do, but there's some focal narrowing which is present in these vessels, which are there, which can be seen on CT angio. It can also be seen in DSA, some narrowing here in the arteries. So when you find these kind of narrowing, plus abnormal MRI, plus some other features, then we can call it, we can think that it can be primary angiitis of CNS if there is no other evidence of vasculitis anywhere else. There's some other examples, like we have that sometimes it is present as hemorrhage, and sometimes can present uh, okay. So sometimes it can present even the spinal cord sometimes is involved. The cord ischemia can cause. Some other non-specific images are here where we can see this focal narrowing which are present on angiography of the brain. There is one new modality which has come is there is high resolution vessel wall MR imaging. This vessel wall imaging can be done. We can find concentric enhancement. If you can see here, the dark one is the blood. The vessel wall is outside. So this is called dark blood MRI. So you can see some narrowing, and sometimes the vessel wall can be imaged by this high resolution MRI. There's a new modality which has come up, and we can use that. But the main definitive thing is brain biopsy or histopathology. The brain biopsy remains the gold standard for definitive diagnosis of primary CNS vasculitis. It can be, biopsy can be targeted when we find an normality on MRI and target that area, or it can be blind. That means without, you can do it at any other site which is accessible to us. It can be open brain biopsy, it can be stereotactic also. And this biopsy should contain samples from dura, leptomeninges, and cortex, and also white matter. And what they have found that there is transmural segmental signs of lymphocytic infiltration and presence of multinucleated giant cells, evidence of vessel wall damage in the form of fibrinoid necrosis. But the problem with this is even with brain biopsy, the sensitivity of brain biopsy is low. It is 54% to 84% at best. And about 25% of the autopsy-proven primary CNS of vasculitis may be false negative on biopsy. So it is both ways. So the sensitivity is low, and in definitive cases also it can be false negative also, but it remains the gold standard for definitive diagnosis. This is some of the examples that they have found that there are three types of varieties of histopathological findings can be found, patterns can be found in primary CNS vasculitis. One is granulomatous vasculitis, which is found the commonest one. This is the granulomatous. You find a granuloma here. On the right side is the granulomatous vasculitis in the brain. And there can be lymphocytic when there's a lot of lymphocytic infiltration around that, which is around 28%. But another variety is this necrotizing variety, in which there is some fibrinoid necrosis in between. So there are three varieties: granulomatous, lymphocytic, and necrotizing. The granulomatous variety is the commonest variety of histopathologically of CNS vasculitis. So what is the differential diagnosis? Now this differential diagnosis, we can, because the first thing is, we find something on angiography, and that is the starting point, that vasculitis, no other thing is there. And we do angiography, found some abnormality, but angiography can also be negative. But those angiography in which the angiography is positive, that means there are some focal narrowing of the vessels on angiography. Even there is a lot of differential diagnosis. The most important is reversible cerebral vasoconstriction syndrome, which can present as focal narrowing of the vessel walls. It can also occur in atherosclerosis, sometime in migraine, familial or hemiplegic migraine. Subarachnoid hemorrhage can cause the spasm of the vessels. Hashimoto's encephalitis can cause vasospasm of the vessels. Antiphospholipid syndrome can cause bacterial endocarditis thromboembolism can cause some narrowing. Vasospasm secondary to any drugs or even hypertension, eclampsia or fibromuscular dysplasia. They can also present with focal narrowing of the vessels on CT, MR, CT angio or MR angio, and they can confuse us with the CNS vascular. That is why they have said that the definitive diagnosis should be by biopsy. But even with the other differential diagnosis include when the angiography is normal, but we suspect that there is evidence of vasculitis in the brain. With normal or angio-negative primary CNS vasculitis can also occur. So we have to differentiate if it is negative from other infections and from NMDAR encephalitis, Hashimoto's encephalopathy, antibody-mediated in autoimmune inflammatory brain disease, Rasmussen's encephalitis, ANC-associated vasculitis, neurosarcoidosis, mitochondrial disease, multiple sclerosis, angiocentric lymphoma, because angio maybe is positive only about 60-70% of cases. So if angio is negative, then these conditions should also be differentiated. So there is a host of rare and common diseases which can get confused with primary CNS vasculitis, and we have to differentiate and investigate for them. And the main problem comes that we have to investigate to differentiate these other mimics of CNS vasculitis. These mimics for these we can differentiate by various investigations, like basic blood tests we have to do, like CBC, ESR, CRP, prothrombin, urea creatinine, LFT, lipid profile, cholesterol. These are the basic investigations we must do. But some autoimmune screening should be done for ANCA, anti-dsDNA, anti-Rho, SSA, SSB, anti-smooth muscle antibodies, anti-RN antibodies, antigens, ENA, ANA, anti-TPO antibodies, anti-thyroglobulin, angiotensin converting enzyme for sarcoidosis, and other autoimmune encephalitis panel may be required to be done to exclude the mimics of CNS vasculitis. Then certain other thrombotic disorders we have to screen out, like anticardiolipin antibodies, lupus anticoagulants, serum B12 deficiency, homocysteinemia, serum of cystinuria, cystinemia, serum folate levels, protein C, S, factor 5. They can all cause thrombosis and leading to some abnormalities in the brain. Some neoplastic and paraneoplastic screening needs to be done. CA125, PSA, antibodies again, the neuronal antigens like anti-Hu, Re, Ma, 1 and 2, and amphilysin antibodies. And then we have to do screening for any infective process, either viral or bacterial. There are a host of viruses which can cause, including SARS-CoV-2, and they can also be mycobacteria can cause also vasculitis, and even Borrelia can cause. So all these things diseases need to be excluded before we can label that is primary CNS vasculitis. CSF examination is an important aspect because this tells us that there is some inflammation which is going on in brain. And this is found to be abnormal in about 80 to 90% of cases. We have to do cells which are slightly increased. Glucose is generally normal. Protein is slightly increased. And we can have to do bacterial cultures to exclude other infective processes. And we have to do some antiviral antigens and antibodies also, like anti-HCV, HBS, HCV, and other viral antibodies need to be excluded in CSF. So CSF is an important aspect because it tells us that there is some inflammatory process going on. So the diagnostic approach should be that first thing that we have to suspect, we find an unexplained neurological deficit, and you start thinking that it may be CNS vasculitis. Then we have to demonstrate the radiological changes consistent with primary CNS vasculitis, which is focal narrowing of the vessel walls, And then we have to rule out the mimics, which is the most difficult part, mimics of the primary CNS vasculitis. And we have to do the host of investigations, which I enumerated earlier. We have to demonstrate neuroinflammatory process in the brain. And for that, CSF is important. And that is why the criteria says that you have radiological, MRI, and CSF. If all these three are present, then we may be there, and we have excluded other mimics, then we can think of primary CNS vasculitis. But consider brain biopsy whenever it is feasible, because that is the definitive diagnosis for primary CNS vasculitis. So since the investigations, if we don't do biopsy more often, so some new diagnostic biomarkers have been postulated, and they would be probably coming up in futures. So we can do interleukin 17 in CSF. Interleukin 17 is a pro-inflammatory cytokine and a potent mediator in cellular immunity. It is increased level are found in primary CNS vasculitis in active as well as in remission. So this can be used as a potential therapeutic target also. So it is increased in primary CNS vasculitis, and there is some studies they have start trying to target this as a potential therapeutic agent. Some studies are going on to target IL-17. You can also do amyloid beta A4 protein, APP, in CSF. This is an indicator of nervous system damage, and decreased level of ASF was found in mass spectroscopy in men. And this indicate, and if it is increased in brain, then it indicates a surrogate marker of brain injury in CNS vasculitis. That means only some damage to the brain is going on. Circulating endothelial cells in venous blood. Circulating endothelial cells in the peripheral venous blood are a marker of an endothelial injury. And we know that in primary CNS vasculitis, it is the vessels which are affected. So the circulating endothelial cells can be isolated by immunological method or flow cytometry. They are significantly increased in primary CNS vasculitis, and they decrease with successful therapy. So they may serve as a useful biomarker in biopsy negative cases, or when we are unable to do the biopsy. High resolution vessel wall MRI I have talked about, showed an image, and we can do an enhanced or a dark blood imaging which visualizes the vessel wall from the lumen and can differentiate the primary CNS vasculitis from other vasculopathies by its patchy nature. Endothelial progenital cell venous. These are all new markers which have not there at the moment, but they are being probed as a marker for primary CNS vasculitis. So they play an important role in the vascular regeneration and repair of the endothelium. And they are a marker for endothelial repair. So if they are decreased, that means some repair is going on, and some vascular repair is going on. So they have an inverse relationship with circulating endothelial cell. So if a circulating endothelial cells are increased, that means there is some damage to endothelial cells. These cells, they are reduced because they are trying to repair that wall. So this endothelial progenitor cells are decreased in venous blood. Von Willebrand factor in venous blood. This is a plasma protein with mainly synthesized in endothelial cells. And when the endothelium is damaged by inflammation, increased levels are found in the blood. So this is found to be increased in Behçet's disease and Kawasaki disease also, which is a form of secondary vasculitis. And it may be used as you can say, for prognosis or for treatment success as a marker if we are treating the patient. Then I told you that high resolution D, apart from the dark blood angiography, MRI, we can also do a 3D rotation angiography, which allows visualization of smaller caliber vessels and perforators. And these smaller vessels damage can also be demonstrated by 3D rotation angiography. And there is something called 4D DSA also, which is time-resolved 3D rotational angiography, which visualizes the microangiographic structure of AVMs and AV fistulas. So these are being probed if we can use these modalities for diagnosis of primary angiitis of CNS, which are not picked up by conventional MRI or CT angio. Even positron emission tomography, it can demonstrate metabolic activity in the inflamed vessel wall, especially the medium-sized vessel wall. But the problem with this is that smaller vessels are not visualized, but this can be used if we suspect that medium vessels are involved by PET scans. These are the various investigations, and the most difficult part is to uh, investigate and differentiate other diseases from primary CNS vasculitis. So once we have found that there is a patient is suffering from primary CNS vasculitis, then how to manage that case. So management challenges are there because first you have to promptly recognize and treat early, because if we treat it later, then severe neurological deficit can occur. Chances of missing the diagnosis are high because symptoms are varied and clinical course is variable. Histopathological confirmation of diagnosis is desirable, but brain biopsy is golden standard, but has its own limitations, not positive in all cases, and difficult procedure, not done at all centers. Secondary causes of CNS vasculitis, they are to be excluded before we think that and start definitive treatment for primary CNS vasculitis. An empirical trial of immunosuppressants and immunomodulators, they are generally cannot be given empirically because of their high side effects of the drugs. So we have to be definitely sure that it is, but there are some the treatment modalities. We have a list of drugs here. For acute therapy, we have corticosteroids and cyclophosphamide. For maintenance therapy, we can use azathioprine, methotrexate, and mycophenolate, and certain biological agents like rituximab, TNF, infliximab, etanercept can also be used. These are the drugs. I'll talk about some of these. So the induction therapy, we aim in achieving a remission of the or arresting of the disease. The initial induction therapy we give is by IV pulse therapy. If the disease is severe, then we have to give IV methylprednisolone 15 to 30 milligram per kg per day for 3 to 5 days, and then followed by oral steroids. But if the disease is mild, then we can give even oral steroid 1 milligram per kg per day, maximum 80 milligram for 4 to 6 months in mild cases. For biopsy confirmed cases, we can use a combination of IV glucocorticoids plus cyclophosphamide. And the relapse rate by combination therapy is much less than with the steroid therapy alone. But the problem is the side effects of cyclophosphamide. So it should be given only in biopsy-proven cases. Otherwise, only steroid is the mainstay for achieving remission. Induction therapy is followed by remission. And in this induction therapy, we can use some other biological therapy in refractory cases before the induction therapy. In refractory cases, that means those cases who do not respond well to steroid or to combination therapy, we can use some biological agents, rituximab, infliximab, and etanercept in the doses mentioned here. They can be given for 4 weeks, or sometimes etanercept can be given once weekly for even up to 8 months. So if the steroid doesn't respond, the patient doesn't respond to that, then in refractory cases we can use these biological agents. Once the remission is achieved, then we have to do a maintenance therapy. And immunosuppressive therapy is given to firstly reduce the dose of steroid. And the drugs used are azathioprine, 1 to 2 milligram per kg per day, methotrexate, or mycophenolate mofetil, 1 to 2 gram per day. These therapies are given for about 6 months or longer till there is remission. After remission, there is slow tapering. So this slow tapering is also very important, especially if we are using steroids. If we are using steroids, which are usually given for 6 months till we found that there is a desirable disease stable, then reduction is done very, very slowly. First, we reduce 10 milligram per kg till about 40 milligram is reached per day is reached. Then we reduce after 1 week of 40 milligram, we taper by 5 milligram per week till about 20 milligram. And then after that, 2.5 milligram per week, and then 1 milligram every 2 weeks. And then we reduce 1 milligram per month. So we have to go very slowly and reduce it. And in case of relapse, we may have to again increase the dosage. And once the patient maintains this disease profile is stable, then we can stop after reduction in slow manner. But once we are using these immunosuppressive as well as steroids, then we have to look after other aspects also. So prophylactic treatment for bone loss should be given, calcium, vitamin D, or biphosphonates. And for preventing opportunistic infection, we have to cover for pneumocystis, cardia, pneumonia. Gastric ulcers can occur, so prophylaxis for that. Anti-epileptics if there are seizures, antipsychotics if there is behavioral problem or hallucinations, or monitoring of the treatment is also being done by one of these investigations which we mentioned, if we can do it, or clinically also. If there is relapse, then we have to treat again. So just to summarize, there was one good meta-analysis of primary anxieties of CNS, which was published in 2021. And they found 46 studies which fulfilled the criteria. And the total number of cases were 911 cases of primary anxieties of CNS. And they found that in total 911 cases, the mean age was 42 years. The male-female was more or less same, 52% and 48%. 41% were biopsy proven out of these 911. 43% were angiogram confirmed, and 16% were without any clear assignment. The DSA, important thing to note is DSA was positive in 30%, 33% of biopsy proven cases. So DSA may be negative. It was positive only in 33% of cases. And biopsy was positive in only 8% of angio confirmed cases of primary anxiety of CNS. So that is why there is a lot of investigation which we need to exclude other causes. So biopsy positivity was only in 8% of angio confirmed cases, but MRI was abnormal in about 97% of biopsy proven and 98% of angio proven cases. And MR angio corroborated with DSA in 74% of cases. That means pretty good. So DSA and MR angio is equally effective, but DSA is of course better. CSF was abnormal in 75% of cases and should serve as a good marker for ongoing CNS pathology. And it was positive in 75% of biopsy proven and 65% of angio proven cases. So the conclusion was that the biopsy proven and the angiographic proven positive patients, they probably represent two different subtypes of primary anxieties of CNS. And these two subtypes can be medium to large vessel vasculitis, which is there in which you can detect by angiography. But when the small vessels are affected, so they may be angionegative, which will be only found by histopathology. So now probably the thought is that primary CNS vasculitis, it represents two subsets, one which is angiopositive and one which is biopsy positive. And the treatment implication is not yet clear. Maybe the treatment remains the same. So small vessel primary CNS vasculitis, when angiogram may be negative, but biopsy is positive, and medium vessel primary CNS vasculitis, when angiogram is positive, but the biopsy may or may not be positive. But if you do biopsy, it would be positive, but angiogram is positive here. But and if it is there, so you may treat them as, if you exclude other causes, as primary CNS vasculitis. Now, this is about primary CNS vasculitis, which we have about in detail, but a little bit about secondary CNS vasculitis also, because brain vasculitis can occur in other diseases also. So, secondary CNS vasculitis, it occurs in the background of other systemic diseases, which in addition to brain also affect other system and other organs like skin, kidney, lungs, sinuses, cardiovascular system, or joints. So it can occur associated with multiple conditions, including systemic vasculitis, certain infections, connective tissue diseases, certain malignancies, and other miscellaneous conditions. Infections, secondary infection, and secondarily affection of CNS can occur in some infections like bacterial meningitis, tubercular meningitis, and viral infections like varicella zoster, HIV, and SARS-CoV-2 vasculitis can also affect brain. Systemic connective tissues like polyarthritis nodosa, rheumatoid arthritis, lupus, Behçet's, they can cause secondarily venous vasculitis also. Systemic inflammatory disease like Kawasaki disease, ANC vasculitis, the polyangiitis, venous granulomatosis, or Church's tract disease, they can also affect secondarily brain and cause brain vasculitis. And certain drugs like hydrolazine, cocaine, amphetamine can cause drug-induced vasculitis also. So, somewhat few representative secondary vasculitis, SARS-CoV-2 vasculitis. So, this was one report of SARS-CoV-2 vasculitis, and which have found that COVID-19 was also associated with CNS vasculitis. But whether it is causal or it was just coincidental is not very clear. The pathology is lymphocytic vasculitis with CD3 cells and some CD20 cells also found on autopsy. And there is parenchyma, edema, necrosis, patchy microbleeds and palms. Diagnosed by serology, light microscopy, immunohistochemistry, and brain biopsy. And common antigens are acute. Common presentations in these cases were like ischemic stroke or subarachnoid hemorrhage. But on biopsy, they found that there was sinus vasculitis. Or on autopsy, not biopsy, but autopsy. Behçet's disease. This is also a multi-system disease, chronic relapsing vasculitis, which can occur, causing secondary vasculitis in brain, and it also affects the venous system. Diagnosis is clinical, and no pathognomic diagnostic criteria is there. Finding is there. The criteria for diagnosis of Behçet's disease that there are recurrent ulcers, oral ulcers, and any two of the following. Recurrent genital ulcers, eye lesions, erythema nodosum, and positive pathology test. If any two of them are present, then we should suspect, plus recurrent oral ulcers, then Behçet should be considered. And neurobehçet sinus involvement occur in about 30% of cases of Behçet's. Neurobehçet's can present after an average period of about 5 years of Behçet's disease, and it can present as vascular involvement causing aneurysm, arterial and venous thrombosis, headache, stroke, pyramidal signs, brain stem involvement, and venous sinus thrombosis. 3% of patients develop neurological signs without even mucocutaneous or ocular symptoms also. And neurobasis treatment includes high dose of corticosteroid, immunosuppressives like the drug which treatment is by and large the same, but we have to differentiate between the primary CNS. The duration of treatment differs in these two diseases. Kawasaki disease is another disease which affects the medium vessels. Is a secondary vasculitis of brain, can affect the brain. It affects mainly children. I have not talked about the vasculitis in children because this is mainly pediatric neurologist age group, but Kawasaki is one disease which affects the children less than 5 years of age. And the features include fever, conjunctivitis, mucositis, skin changes, lymphadenopathy, and cardiac involvement. CNS involvement can cause aseptic meningitis, headache, convulsions, irritability, seizures, ataxia, and encephalopathy. So, lastly, the drugs and substance abuse vasculitis. Some drugs can cause that. IV abuse can cause thrombosis in the veins and arteries, and they can cause arthralgias, myalgias, skin rash, can occur, aneurysm, hemorrhages, and non-hemorrhagic strokes can also occur. The treatment is just avoid the exposure. Some common drugs are cocaine, amphetamine, antithyroid drugs, and hydrolase. So to conclude, the CNS vasculitis can be primary or can be secondary. Primary CNS vasculitis is rare but quite devastating. Current diagnostic criteria of primary CNS vasculitis is low. It has low sensitivity and specificity. Common clinical manifestations include headache, stroke, seizures, encephalopathy, or any non-specific neurological deficit. Diagnosis requires high degree of clinical awareness, although investigation to rule out secondary vasculitis through a thorough investigation to rule out secondary vasculitis and radiological mimics. That is why a host of investigation need to be done before we can say it is primary CNS vasculitis. Brain biopsy is still the gold standard of diagnosis of primary CNS vasculitis. but it has low sensitivity due to sampling error. And radiological mimics are also very common, especially reversible cerebral vasoconstriction syndrome, which is the most common mimic of primary CNS vasculitis. Glucocorticoid alone or in combination with cyclophosphamide is the first line of treatment. And although there are no RCTs for that, secondary vasculitis is more common, but has varied causes, and we have to treat the cause as and when whatever the treatment remains the treatment of the cause. So this is regarding the CNS vasculitis. Thank you so much. Video.
Thank you, sir.
Thank you, Dr. Sharaf, for an excellent coverage of the topic. And it's a little bit difficult topic and a rare topic. So there are a lot of mimics. What is your take on for the antiplatelet, like in the patients with the tubercular meningitis and vasculitis, we are giving antiplatelet for in the patient with the CNS vasculitis, primary CNS vasculitis, so we can go with the antiplatelet also aspirin.
So in tubercular meningitis, the antiplatelets role is limited because the main pathology is infection only. There is no study which suggests that and is there any role of any aspirin or any other antiplatelet agents in primary CNS vasculitis, as far as I could get any literature. But there is some report which says that there is an inflammatory process can be, you can probably modify them by using anti-inflammatory agents, like we are using steroids. But specifically only aspirin, I have not come across any report suggesting that it can be used in primary CNS vasculitis.
And like for the relapse, for making the diagnosis of the relapse, so for the 3 or 6 months, you go only with the neuroimaging or you go with the CSF study also. Like when you recommend both the things like CSF and neuroimaging or only the neuroimaging.
The start point of diagnosing is that you suspect CNS vasculitis. That means there is some neurological deficit and some abnormality in MRI. And we find that the common causes, or for example, say stroke, the no risk factor for a stroke in that patient. Now, then we do an MR angio. Now, if we find an MR angio that it is got some narrowing or suggestive of a vasculitis pattern in the brain, and there's no other organ involved, then we can, there is one more ground for assessing. Then we have to also demonstrate. Then after that, we have two options. Either we do a biopsy of the lesion or we do a CSF. So CSF is easier. So then we do CSF. So if you find that CSF is abnormal, the MRI is showing vasculitic pattern, and then we go for excluding all other host of other secondary vasculitis. If we excluded that, then we can label them as probable primary CNS vasculitis as per the current criteria. And when we see it probable, then we don't give cyclophosphamide then, but we can give steroids. So steroids are given, and if they give a good response, then we continue steroid till the response is there and the patient is stable for about 6 months or so. After that, we taper off gradually. If on tapering, there is relapse, then we have to do second line drugs like rituximab or etanercept or something. We can try that, but although not many studies are there. And then we treat them again with higher doses of steroids. But if the patient is willing and the facilities are available, then brain biopsy should be done. If we find evidence of CNS vasculitis in brain without any evidence of vasculitis elsewhere, then we can label it definitive vasculitis. And in that case, we can give a combination of cyclophosphamide plus steroids. So in that, if you give both of them, then the response rate or relapse rate is very low. And the response is also good. But unfortunately, without a definitive diagnosis, there are a lot of neurologists, they are scared to give cyclophosphamide because it is to be given in high dose and it has a lot of side effects. So that is the issue, the problem with CNS vasculitis. Have I clarified the point? Or
Yes.
you
Thank you, sir.
confused?
It's a very difficult topic. There are a lot of DDs and
Yes, ma'am. Yes, ma'am.
very
Main
high
point-
index of suspicion is required.
So I think now to start point would be that we find some neurological deficit and uh, and we don't find a cause. That is the time we should either do a CSF or do MR angiography to rule out if there is vasculitis. Because unless there is high index of suspicion, we start point is like this. If we don't find any of these, then we are nowhere. Then we can't proceed. Either CSF should be abnormal or the radiology is abnormal uh, before we can say that it is CNS vasculitis. But that is why we are missing also probably many cases. Because we also see many cases where have some abnormalities, but we are not able to fit into one particular syndrome. Maybe they are the ones.
Session is open for question and answer. If any question is there from audience,
It's a not very common topic, so may not be. I don't know if but
Well,
any
this is very important topic which we often miss in our day-to-day practice. I think definitely high index of suspicion is required for diagnosing these cases, and I think no one is doing asking for brain biopsy. All are diagnosing on MRI,
yes,
characteristic features, MR angiography, as well as this CSF.
yes,
And I think making a diagnosis is also very difficult because a lot of investigation is required to reach at some certain diagnosis. I
very
think
true.
none of us is or asking for such a vast list. We only go for first exclude the secondary causes. I think this infective and this malignancy related causes, and even when these come negative, then we go for other say causes, other tests for primary. I think CNS meningitis.
Very true.
So, what is your take on the take home message? The one with high index suspicion, and what investigation should be ordered in high suspicion? Because the list is very long.
Yeah. So
Which diseases should be ruled out first?
no, before ruling out the diseases, first thing is that we have to uh, say that there is CNS vasculitis. So first thing is to demonstrate that there is abnormal angiography of brain. So
Yes.
we have to do MR angio or CT angio, and if we find abnormal radiological angiography, then we have to exclude common causes. I think infections should remain one of the most common cause, followed by the rheumatological causes, other immunological like ANA. And these two things, if you can exclude, then maybe some rare infections we can maybe omit, which we don't see very much. For example, COVID. Also, SARS-CoV-2, that is now not there, so we may not look for that. But some common infections like some viruses, viral screening is pretty important. Now, viral screening, now some new techniques have come, biofire and all, and where you can do some lot of screening of many bacterial infections at one go. So if biofire comes, then maybe it will be easier. The first thing is to suspect, then demonstrate abnormality, and then maybe exclude infections and rheumatology.
Sir, what is the role of aspirin or antiplatelet? As ma'am asked, uh,
By
I asked
aspirin
you.
and antiplatelets,
So, in which vasculitis we should give antiplatelets? Infection, you have denied that it should be not be given any infective vasculitis. Is there any role of aspirin if suppose the patient is having rheumatological disease? Is aspirin indicated?
whatever I have read, I have not found that when the primary pathology is vasculitis, then antiplatelet has got any role. There are one or two reports I was just reading somewhere that anti-inflammatory, then the aspirin can be used as an anti-inflammatory also. So maybe that has anti-inflammatory process may be used.
But that required large dose.
Large dose,
75
yes.
or 50 milligram do not work as anti-inflammatory.
So antiplatelet, I have not come across. If any one of you have read or used that, I'm open. But we are not using, at least in tubercular meningitis or any infective pathology, antiplatelets, including aspirin.
So I think non vasculitis require aspirin. If patient is having a stroke, small strokes, and if we found the primary vasculitis, primary CNS vasculitis, then is there role of aspirin, or even then there is no role of aspirin?
I don't think there's any role of aspirin in that because the primary pathology is vasculitis. It is something like
Okay.
tubercular vasculitic infarcts. So if there is a lacunar infarct following tubercular meningitis, then I don't think we are using aspirin for that in that case. A similar analogy is there also because we are
Okay.
not using aspirin in tubercular vasculitic infarcts. We are using only anti-inflammatory and steroids plus an ATT. But I don't know if there is any new studies that have come recently. If you have, I'd like to know about it.
Rajesh Verma sir,
Yeah. Dr.
sir,
Khan can
Rajesh
actually,
Verma sir,
The learned people are here, so yes, sir.
Verma sir, need your comment on today's elaborative talk on vasculitis. Jari sir has very nicely elaborated everything about
I
vasculitis.
think it's a wonderful talk, and he has covered almost all the aspects uh, of this complicated topic, and we have idea about the various types of primary and secondary vasculitis. I think he did a commendable job. So big round of applause for Dr. Sharad Dhari. And I think um, it's it's a nice overview of such a lengthy and vast topic. As far
Yeah.
as the role of aspirin is concerned, I think there are some proposals in the literature. In fact, Dr. UK Mishra and then some scientists from other part of the world, and we did also a study about the whether there is presence of platelet dysfunction in patients of TBM. So we also got some positive analysis about the platelet dysfunction. So we also made this conclusion, probably we can use aspirin to prevent the infections in patients suffering from tuberculosis meningitis, because you see, there is a rate of around 17 to 72% of stroke in patients of TM. So many patients of TM die not because of disease per se, but rather because of these devastating strokes. And sometimes they become disabled for lifelong. So I think we cannot say blanket, I mean to say no or yes. Yes, there is some emerging role of aspirin. And a meta-analysis was done in our department that also concluded with the remarks that aspirin can be used, can be administered to prevent the strokes in TBM, but it does not decrease the mortality actually. In that paper based on some observations of the previous scientist. But because if it is a endothelopathy, so if there is an endothelial dysfunction, then there is definitely can be some role of I'm going to say antiplatelet agents. If it is a media intima, tunica in media involvement or tunica external event, then I think there is no role of platelets, because platelets basically, where there is a some endothelial dysfunction, so there is some deposition of platelets, and then of course formation of thrombosis.
Thank you, sir. Thank you very much for a nice comment.
But
So I
sorry,
request chairpersons to have their comments.
You see, the serious vasculitis definitely is a very difficult diagnosis, but you have to suspect whenever you confront with a patient of this subacute headache, cognitive dysfunction, and then when you go for in this patient, definitely you go clinically. It's very difficult to suspect, but when you see the MRI of those patients, angio of those patients, they'll see some sort of bleeding appearance in the leptomeningeal or small vasculature or like that. Although that is very non-specific, because you can see in fibromuscular dysplasia, you can see reversible vasoconstriction syndrome, you can see many other conditions. But of course, the clue comes from the angiogram. Yes, my patient is probably suffering from primary CNS vasculitis. And here the story starts. Because if you say biopsy is not 100% sensitive, then what investigation, what is, I mean to say, what is the gold standard? Uh, if it is sensitivity is hardly around 80 to 84%. So then whenever this type of conflicting situations, I mean to say you cannot diagnose this CNS vasculitis with certainty with a gold standard, then of course then you have to take into account that, or it should be a criteria-based diagnosis. If you're getting such and such clinical as well as NGOs, and then of course these markers, biomarkers, and then of course biopsy. Because therapy, basically, whatever you offer, is we have to give it for a long term, and it can pose a lot of side effects, especially when you are giving immunosuppressants. So be sure about the diagnosis of CNS vasculitis before starting the therapy in these type of patients.
You are right, sir. The problem with biopsy is not that it is the sampling error which is there. Because if you do autopsy, maybe you will find. But in the living person, you do biopsy from one particular place. Because it is a focal not involvement of the vessel wall is not throughout the CNS vasculature. So that is why it is missed. So, but that is, they have kept it as like this, that if it is, you find it, that is definitive. But post-mortem diagnosis can be there. So that is why now the thing is that probable CNS vasculitis, primary CNS vasculitis, may be treated more vigorously. Regarding aspirin, you are right, sir, because theoretically it should work. But the thing is, it is something like that, like post-stroke seizures. So we as neurologists, we generally, there's no class 1 evidence that you give anti-epileptics in post-stroke seizures. But many of us, we give also, especially cortical strokes. Similarly, in the tubercular vascular infarcts also. I think it requires some kind of maybe double-blind study to see if this is making any difference or not. But this is a major issue, as sir is saying. The vasculitis following tubercular meningitis is more devastating than the TBM itself. Because TBM is treatable unless it is resistant kind of thing. But they have disability or death because of the vasculitis associated with TBM. So, but sir's point is very valid. It should work, but I am not aware of any study which is being done to say that.
In fact, I have published a study in neurological sciences. There is a PET function and cognition parameters in tuberculosis meningitis. But this is a small sample size study, so we cannot. It cannot become class 1 evidence. But there is a noise from various parts of the world, because TBM is a very devastating disease, and we see day in and day out patient die from TBM. Maybe
I'm sure that would be useful. Yes, I'm sure it would be useful if we use it.
So I believe a large multi-centric study is required to assess the role of aspirin in TBM to prevent strokes.
It can only be done in India, but
this
unfortunately,
challenge is taken by the Indian scientists, but unfortunately, majority of studies they are picked up by the single centers, the small sample, and then the world does not give that type of recognition to that study. So I think a national level, just like ICMR, they should undertake this challenge, and they should give this responsibility to various centers.
very true. Very true.
Is there any other questions from the audience?
So there is a one article in NEJM review article in 2024 in that in the European guidelines they have said that like we can add low dose equisprin in cases of medium and large vessel primary CNS vasculitis. So yes, we can go with this, and Yes, the sir has said like for in the tubercular meningitis, it does not prevent the mortality, but definitely it has the role in prevention of that stroke and infarction.
Yeah. There is one article in recent in September in New England Journal, but maybe there is some article I have missed out. Quite possible.
I just want to make one comment, Dr. Kankane. Am I audible?
Yes, you're
Yes.
audible.
Yeah. Actually, we usually treat these patients with TB, vasculitis, yeah, CNS vasculitis, primary or secondary, with high dose of steroid, right? So steroid itself has got antiplatelet property also, as well as apart from being anti-inflammatory. So I had always a doubt whether antiplatelet addition to steroid would make any difference. But since there are studies, definitely there are studies from this part of India, like from UP, SGPGIMS, from our center, which showed that addition of aspirin uh, definitely adds some benefit. May not be very drastic difference in outcome, but some benefit. So low dose aspirin can be added. Another thing regarding clinical pointers, which we should suspect in a patient to have a CNS vasculitis, because these patients can be of older age group, and in those patients, finding an MRI, typical MRI like small infarcts, angiographic abnormalities, can be misleading. So whether we should go for CSF examination or not. So I may, matlab, Dr. Johari may correct me, but I feel if there is, because we have seen one or two patients in our practice here, if there is associated some sort of confusional state along with infarcts, and as he pointed out, we don't find any other risk factor apart from being age, we should go ahead with the CSF examination. There may or may not be history of headache. And if CSF proof turns out to be inflammatory, then it can be CNS vasculitis.
No, you are right, sir. Because I told you that that two, three things you have to approach. First thing you suspect. Second thing is that you demonstrate that there is CNS vasculitis in the form of by angiography. Third thing, you demonstrate that there is some inflammatory process going on. For that, you do CSF. If CSF is abnormal, the angiography is abnormal, suspicion is of CNS vasculitis, other investigations are negative for other tests, then it is probable CNS vasculitis and we should treat like CNS vasculitis. You're right, sir. And CSF is one of the important study to be done in all cases of CNS vasculitis, not biopsy proven. Without biopsy, it's at least.
So when there is the absence of conventional risk factors, and if you get a patient who is having recurrent stroke or like that, so then I think, and then angio shows some sort of beaded appearance. I think there we should suspect CNS vasculitis.
Very true, sir. Very true.
Because of course, every patient stroke, we go for a positive battery of investigations, whether it is atherosclerotic or whether it is embolic infection or whether it is artery-to-artery embolization or like that. So sometimes yeah, there are no risk factors, high blood pressure, diabetes, or dyslipidemia. Heart is okay. No, there is absence of, I mean to say, clot in the left atrium. Aorta is normal. So then, and even the extra, this carotid, that is also normal on study. So then, if patient having recurrent strokes, maybe TI followed by a full-blown stroke and absence of all these risk factors, and there is some more addition of maybe some subacute headache or dizziness or maybe some cognitive deficits. I think in that situation, you have to suspect CNS vasculitis.
Very true. Very true.
And of course, this basic marker like ESR, CRP, these markers of, I mean, serum markers of inflammation, general inflammation, inflammatory markers. So I think because finally, if we don't suspect early, then it can lead to a lot of deficits, and then patient can have permanent deficits, this disability lifelong.
Yes.
Yes, thank you very much, sir. Thank you for nice comments. Thank you for enlightening us about the this
So
CNS vasculitis. So
why I'm taking interest, because I have been given a topic to speak on neurorheumatology. So when I go through how this neurology and rheumatology can be combined, and within 20 minutes, what to speak and what not to speak, so there were a lot of questions in my mind. And then one of the, I mean to say, important condition, which can be a sort of between neurology and rheumatology, a sort of immune-mediated disorder, mediated vasculitis. So I love this lecture actually. I really admire Dr. Shadjari. I mean to say, it's such a nice flow of thoughts, starting just like a chapter. So, if you can give me a favor, I want these slides or presentation YouTube format or like that.
Yes, sir. Yes, sir. I can send it by email, sir. If you there is nothing like that. So,
Wonderful, sir. Highly impressed with you.
if you want these
thank
slides,
you.
आप you just मैं सर से ले लूंगा, आपका ईमेल ले लूंगा कनकने डॉक्टर कनकने से, तब उसके बाद आपको भेज देंगे.
नहीं, ठीक है, sir.
Definitely, sir. So thank you very much. I request to Dr. Archana ma'am to do the honor of Dr. Jawhari sir, virtual honor. So
Oh,
So this
thank
is for you. So such a nice presentation, sir. So very elaborated and extensive presentation. Thank you, sir. Thank you so much.
thank you, madam.
sir, you'll have a physical certificate of appreciation in our conference next month. So you are invited over there, sir. You'll have the physical certificate. This is probably I think the last virtual CME of this year, because next month we have the physical conference at KG at Lucknow,
Yeah.
organized by Sanjay Gandhi PGI.
Yes.
So all participants who contributed in this all virtual CMEs will get physical certificate as well as plaque also. So this is just a token of appreciation. Actual honor we will do at the conference. So please do come over there, sir.
Thank you,
Thank you, sir. Thank you very much.
So,
Thank you, everyone, for attending this
correct,
virtual CME.
to deliver this lecture again on the platform of conference, then you
It may not be of much interest to, I don't know, because conference में तो, but there is no issue. But now you have heard about it.
Thank you, sir. Thank you very much.
नहीं सर, ऐसे ही चलता है सब एजुकेशनल
हाँ
कंटेंट.
बिल्कुल सर, नहीं इट इज, मैं भी जरा देखता हूँ अभी जो आपने बताया. बट आई थिंक दैट इज जो सर ने कहा है, प्रवीण सर ने, कि भाई आई थिंक द रोल ऑफ एस्पिरिन नीड टू बी evaluated at a larger scale. Okay, sir.
Thank you.
Thank you, sir.
Right,
Thank
sir?
you very much.
Thank you, sir.
Thank you both of chairpersons, Dr. Praveen Sharma, Dr. Archana ma'am, for staying with us and for taking this session. So thank you everyone for attending this virtual CME. So
Thank you for giving me this opportunity. Thank you so much.
thank you, Joyce. Thank you, Shraddha Joyce, sir. Thank you for
Thank you,
nice
sir.
and
Thank you,
elaborate
sir.
talk.
Can we
So
disconnect now?
yes. Good night, everyone.
Good night.
Namaste, sir.
Night, everyone. Good
Good night.
night.